We're going to move on and have a look at the cranial nerve exam. Fills even the most senior non-neurological clinicians with dread looking at the cranial nerve exam. But I think I can show you guys a fairly quick routine for getting through the cranial nerve exams. I can do a screening cranial nerve exam in less than a minute, so it's actually not that complicated once you get going. As I've banged on about a lot with these videos, the instructions are really important to the patient, particularly when it comes to the cranial nerve exam, because there's a few things the patients can do that make subsequent investigation of the next nerves a little bit difficult, or other functions, if they haven't followed your instructions explicitly. Now, I don't myself clinically examine the nerves in numerical order. They weren't written in any sense they weren't numbered in any order that would make you think that that's the way you should do the exam. But we'll move through, at least in batches today, of the various different nerve numbers, because that's probably a helpful way for you guys to consider. If you do just do them directly in the number order, you come back and forth multiple times throughout the exam. It doesn't look great. The first nerve, of course, is the olfactory nerve, and you'll never be asked to examine someone's sense of smell. As a screening question, you can ask if food in particular has lost its flavor, because smell is such a huge component of flavor, and that can indicate an olfactory pathology. Bear in mind, though, that there are other neurological conditions where the sense of smell is lost. That's called anosmia, and that's particularly seen as a non-motor feature of Parkinson's disease. So it's not just that you've had a lesion of the cribriform plate injuring the olfactory nerve to give you a cranial nerve 1 lesion. So skipping the first nerve, we'll move on to the second nerve, which of course is the optic nerve, which is the nerve we use for seeing. And there's various orders in which you can do this, but I would take anything that involves shining light into the eye and put it at the end, because it just makes the other parts hard. If you've impaired the patient's vision by shining a really bright light in their eye, it's very hard for them to see thereafter. And so the first thing to do is to establish that the patient can actually see. I have a not very good card today for examining visual acuity. This is one from one of the eye companies, but that I picked up at a lunch one day. John's just holding up a big Snellen chart. That's actually not helpful for the exam either. That's what this thing looks like. It's got letters, and it's also got shapes for non-English speakers, so you can just use shapes and symbols instead of letters. But this has to be at 3 meters, and you're going to be on the other side of the room if you want to do it that way. So I wouldn't recommend that you use this. What I would suggest that you get, and I had a set of these for my clinical exam, I've forgotten where they are, but I would get the cards that are printed. They're about the size of an index card, and they've got the Snellen chart printed on it, and it says use it 60 centimeters or something like that. And it looks slick in an exam if you have 2 of them joined with a piece of string at 60 centimeters. Right? Yeah. Because what you can do is give the patient one of the cards, and imagining this is one, and I've got a string out here that's exactly 60 centimeters, and he's able to read back and see what's on the card. And the really clever part about this is it looks good for examiners, but also he just puts the card in front of his eye to occlude vision in the eye that isn't being tested. And I can't stress to you how important that is, because I have this problem all the time in true clinical practice where I say, cover your left eye and read the smallest line you can read, and people push on their eye. They push physically on the globe. And then they take their hand away and they're like, oh, I can't really see properly in that eye anymore. Because they've deformed the shape of the cornea for a few seconds. It can last a couple of minutes because they've been pushing on their eye too hard. And this happens even though I say to people, cover your eye, please don't push on the eye itself, just cover it. But you can only instruct people so much. But if you've got a piece of paper with another piece of paper on a string, you can get them laminated so they're easy to clean and they last longer, then you avoid that problem completely. So that would be my recommended way for actually doing it in real life exams. We don't have that benefit today, so we're going to make do with what we've got. The instructions are still the same though. So, William, I'd like you to take this card in your hand. This one is accurate at arm's length. And lightly place, that's right, that hand over your left eye without pressing on the globe. Can you read the smallest line for me that you can read?
AELGHCT.
Great, and he can read the smallest line, which is 6 on 6. So that's on 660. That's good. Cross over, and we'll do the other eye.
So CLHNA.
Okay, so not quite as good with that one.
Bottom one is a little clearer.
Right. Okay, but that's fine. So you get the principle. You don't need to ask them to read the whole card. It takes too long. Because remember, you're under time pressure when you're doing these exams. So just give them very explicit instruction. Please read the lowest line, which you can read for me. Okay? And we've managed to get that established. We are not ophthalmologists. We are not interested in refractory error. We don't care about pinholes and stuff and can they see with glasses on. So we just want a gross estimation. What's the patient's visual acuity? Can they see? That's all we really care about. Okay. Good. So that's visual acuity. Next, we want to check visual fields. This is, I think, technically the most challenging aspect of probably the whole cranial nerve exam, because if you don't do this correctly, the results are meaningless. It's really important that, again, it's the same concept that it's a fair fight. So we have to be an equal distance apart, and the target that I'm providing him has to be in the middle of the two of us. And William and I have to be at the same height, because if I'm up higher than him, it's artificial. And I've got to give him explicit instructions about what I want him to do. So we've got to be an equal distance apart, the target's got to be an equal distance apart, and he's got to be clear about what I want. So this is done best if you're able to wink in each eye. I cannot physically, I don't know, I have a cranial nerve palsy, I cannot wink in my left eye, true story, so I have to cover my eye, but ideally, those of you who are normally endowed with cranial nerves won't have to do that, but I'm going to show you the hard way to do it by having to cover your eyes, but we'll do that now. So, explicit instructions again. William, I'd like you to lightly place your hand over your left eye, and then I want you to look into my left eye. I cover my right eye, so we're looking same level, same field. And I say, William, I want you to just tell me when you can see my finger wiggling.
Now.
You can probably see it. And I want to check, and I want to be seen to be checking that my hand is equidistant between the two of us. If it's here, it's too easy for him. If it's here, it's too easy for me. Okay? That's the concept. Peripheral vision is designed so that we don't get eaten. Right? It was for seeing things moving in the field of vision so you could run away from something. It is not high acuity vision out there. So you should wiggle your fingers. You see people say, oh, you're making it too easy. No, the whole concept is to get peripheral vision, which is geared towards movement. So you should wiggle your finger so that the patient has a fair fight. And you should do this in quadrants. Visual loss is in quadrants, not halves most typically, and so we bring it in. Okay? Now, we now want to check the other side, but I can't wink in this eye, so I have to change hands, but William doesn't. So I said, William, keep your eye covered for me. I bring this hand over onto my eye, and then I bring my finger up, again checking to make sure we're equidistant, and he can see it, and I come in from the other side.
Yeah.
Okay, now we swap into the other eye. William, you look here into my right eye. I'm looking into his left eye. It's easy on this side, same again, same again. Cross over, come up, come up. Okay? And that's actually a pretty good way of detecting a visual field loss. You will find quadrantinopias doing it that way, provided you're at the same height, the target is in between the two of you, and you use quadrants. Okay, so that's visual fields. Then we move on to motor. This is the ability to move the eyes around. Again, as I've mentioned before, patients want to help and they want to do well in the exam, and so they'll often move their head around to follow your finger. And experienced patients know not to do this, but I think it's worth just guiding the patient. So what I do is I say, William, rest your chin on my finger and keep your head still. Now you've stabilized the patient. You're going to do exactly what you want. Look at the tip of my tendon hammer for me. Follow it with your eyes. And I draw out the letter H. across, we go up, and we go down. Okay? And William's got normal eye movements, obviously. Okay? And I've kept his head still so he's not cheating or helping with the exam. So this action, as we make the bar across here, is smooth pursuit. We can also check for saccadic pursuit, the ability to move the eyes quickly from one side to the other. And that's done as follows. So again, we set instructions for the patient. William, I've got my hand and I've got my fist. I want you to look at my hand, now look at my fist. Hand, fist. Hand, fist. Good. And then we do up and down, hand, fist. Hand, fist. And William can get the whole way across in one swoop. Right? And that's normal. What we're looking for are things called hypometric saccades. Right? You got to skip across a few times to get the eyes to do that test and to complete the full range of motion. William doesn't have hypometric saccades. Of course, it's a sign of brainstem cerebellum pathology. He doesn't have that. Okay, that's also a little bit showing off. Maybe not even in your books, but it's a good one to know how to do. And it only takes a few seconds, and you've done something that's potentially impressive. Okay, we've looked at 2, we've looked at 3, 4, and 6. And we still have some 2 functions to do, right? Because remember, I said we're going to do the pupils at the end of the eye exam. And now we come to the point where we need some light. John, could you pass me the torch?
Sorry.
I said pass, not throw. We'll do a higher centers exam for John later. I see a lot of patients, I see a lot of students, doctors, junior and senior, using an iPhone for the pupil stuff. And the blight of an iPhone is just too damn bright. These torches, you might think that they're cheap and sort of not very good, but they give a gentle light for a reason, and that's it. We just want to elicit the response. We don't want it to hang around for a long time. And so I wouldn't be using an iPhone or Android light. They're too strong. We might see if we can do this without dimming the lights. And if you come close, we'll see if we can elicit it with this level of light. So the first thing to look for is accommodation. And again, explicit instructions for William. William, I want you to focus on a point in the distance, look at the wall, and then I want you to look at the tip of the tendon hammer. Wall, tendon hammer. Getting closer, wall, tendon hammer. Wall, tendon hammer. Good, and can you capture that with...
Shall I zoom in on his eyes?
Yeah, zoom in on the eyes while we do that.
Okay.
Looking at the tendon hammer, look at the wall. Look at the tendon hammer, look at the wall. Yeah, so hopefully you're capturing their accommodation. So in order to assist the lens in bending the light to look at something near to you, you bring your eyes in together and the pupils constrict. And that's called accommodation. Okay? Then we want to look at the ability of the second nerve to carry light. And we want to look at the ability of the third nerve to send motor signal back out in response to light. The first one's pretty obvious, and we've already established that William can see, but we want to see if he's had optic neuritis in the past and what his pupil response is like. And so we come from the side with the light on, and shine. And we get a nice, crisp response. Nice, crisp response. We've got a lot of light here. William's got nice blue eyes, so we're able to see the pupillary response. If you've got Asian patients, Indian patients, patients with dark brown eyes, it can be a little bit more difficult. You can help yourself by putting your hand here to stop the light from washing across to the other side, and you bring out a slightly stronger pupil response. That's one trick for getting around the inability to see the pupil very clearly. Okay? Once we've done that, we then want to check the third nerve's ability to send signal back out. Now we know that each eye responds nicely to light. But what we want to see, if one didn't, that would suggest that the second nerve is impaired, that the patient has had optic neuritis in the past. What we would want to see is, when I shine the light in the good eye, in the other eye, does the other pupil constrict? And that's the consensual response. It doesn't involve the second nerve. And so very often patients who've had optic neuritis will have this thing called relative afferent pupillary defect. Again. And I'll get my hand out of the way so you can see it, but the goal here, look, and quickly move between the two lines. Now, obviously Williams' eye response is normal, but what we're looking for is a paradoxical dilatation of the eye when I shine light in the bad eye, because the second nerve isn't doing its job, but then appropriate constriction of the bad eye when the light is shone into the good eye. Okay? Hope that makes sense. But that's the technique for doing it. Don't do it slowly. This is a quick back and forth, eye to eye, focusing. I'm only ever looking at what I suspect is the bad eye to see if I've got this, as I said, idiosyncratic dilatation of the pupil when light is shown into the pupil. Okay. We skipped one, we've done two. We've done 3, 4, and 6. We can now move on to the 7th nerve. As you know, the 7th nerve has some sensory functions involving taste. You're never going to examine those. We just want to see the 5 divisions of the motor function of the 7th nerve. There's some politically incorrect acronyms for remembering it, but the one that we can say out loud is to Zanzibar by motor car. That's a safe one. So the instructions that you give are, when you just look up at my fingers, close your eyes tight like you've got soap in them. Again, very explicit. That's great. You can open your eyes now. Puff out your cheeks. That's good. Making sure there's good tension there. And show me your neck. Checking platysma from the cervical division. Okay? And that's really all you need to do for the 7th nerve. When I come to do the 7th nerve, this is how I make the point about integrating these things slightly. When I come to do the 7th nerve, I've just done all those muscle functions. So I also ask the patient, bite down hard for me, open your mouth, keep it open. Checking masseter and pterygoid function, which is, of course, the motor function of the trigeminal nerve. Okay? There's no need to be jumping around back and forth to keep the numbers in order. Just do the systems as they flow to you. Okay, having done the 7th, and just checked motor of the 5th, we can now check sensory of the 5th. And again, we want to use a pin that does not cut the skin, and hopefully one where the top comes off without taking the whole pin with it, as this one is doing. Well, that's an equipment failure. Hopefully that doesn't happen to you on your exam day. You'd be certainly well within your rights to ask for another pin if that did. But this is still going to be a little bit sharp. So again, we want to establish terms. Does that feel sharp?
Yep.
And then we check. One, sharp?
Yes.
Feel the same on both sides?
Yes.
Same on both sides?
Yeah.
Same on both sides. 3 divisions of the trigeminal nerve that we want to check. Again, not capping that, putting that in the sharp spin when you're finished. 3 divisions of the trigeminal nerve, all checked. We can now come and check the 8th nerve. There's a few different ways you can do this. Does that sound the same on both sides?
Yes.
Or you can distract with this ear
88.
to check the 8th nerve. Okay. Rini's and Webers. Again, I would never do them in anything other than a formal setting. But you want to check, is the problem with the conduction through air or with the sensory neural conduction or conduction through bone? So you give it a whack and you say, do you hear that equally on both sides?
Yes.
Yes. And then you come and you can put this on you include this here and put this on the bone back here on the bony prominence and ask, can you hear that vibrating there?
Yes.
Okay. And you'll be able to detect if there's a loss in one side or the other if the patient has experienced sensory neural hearing loss. Again, screening test. By no means diagnostic for true hearing loss. You need formal audiometry for proper testing of the 8th nerve. Okay, then again you can just move on numerically. We'll say, William, can you stick your tongue out for me? So what we want to do is get the tongue out. Looking at the tongue comes out symmetrically. Right? If there's a lesion, the tongue will be driven towards the pathological side because the muscle is lost on one side, not the other. And We also want to ask William to say, I'm looking for the palate rising symmetrically, and is the uvula midline? And it is in both cases. Then I want to ask William, shrug your shoulders up for me strong. That's very good. Turn your head this way into my hand. Turn your head this way into my hand. And we've just done 9, 10, 11, 12 really quickly. It's not a particularly onerous thing to need to do. So like I said, that's not particularly long or involved. By far the hardest part is the eye examination. And typically, I had on my real FRACP exam, please examine this gentleman's eyes and proceed. It was not a full cranial nerve exam. There's no way I would have gotten through a full cranial nerve exam. So you will usually be asked to do discrete parts of it. But as you can see, it's actually, if you break it down into its constituent components, it's not particularly onerous. Okay, thanks, Wayne. Okay, there are a few reflexes in the cranial nerve examination which I didn't mention as we were going through, but that you should know how to do. Usually, I would say almost always, you'll be waved off of these aspects of the examination by your examiners because they're unpleasant for the patient, but it's good to be able to volunteer it, and then you never know, every now and then they may say, yes, please proceed, that'd be fascinating. The first is the corneal reflex. And the corneal reflex is performed with a piece of cotton wool, and you should always take the cotton wool from a sterile batch of cotton wool, and then tease this out. Of course, it's not sterile the minute you start putting it between your fingers, but at least you've made the effort. And you tease out a sort of twig of cotton wool. And the trick with the corneal reflex is to, again, as in other parts of this examination that I've mentioned, be looking in the right place. Because what you want to check with the corneal reflex, and I'm not actually going to do it to him today because it's, he doesn't want his eye tickled, but I'll show you how you would do it. William, I want you to look all the way over to your right for me. And then I approach the eye from this side, and I tickle the sclera on that left eye in the far left corner. But what I'm looking at is not to see if the left eye blinks, because it will. I'm probably going to touch the lashes. That's not the trick here. The trick here is to see, is there a signal coming across, is the reflex arc intact to get the eye to blink on the opposite side. So you need to be tickling here but looking on the other side. And that's how you do a corneal reflex. The gag reflex is performed by taking an orange stick, those are sort of a long stick with a cotton bud on the end of it, and tickling the palate. You will never be asked to perform a gag reflex in an exam. If the patient vomits all over the floor, everyone's going home. But it's good that you say you know how to perform it. The other thing you need to know how to perform clinically, William's looking frightened because I'm coming at him with a tendon hammer. You need to know how to do this clinically because it's very important in patients who've got what you think is a high spinal lesion, determining whether or not they've got central pathology in their brain or if it's truly spinal cord, and that's called the jaw jerk. So what we want with the jaw jerk is to ask William just to let his jaw drop open, and then I'm going to put my finger on here, and I'm going to give a tap with the hammer. Okay? And a jaw jerk, the patient will clench their jaw. William doesn't have one. You can have a slight jaw jerk, that's normal, but what we're looking for is an exaggerated response. And that's how you perform a jaw jerk. I mentioned it right at the top of everything, the importance of knowing how to look like you know how to use the equipment. And so that means being able to engage the ophthalmoscope. You won't be able to use one of these fancy ones in an exam, but being able to engage the ophthalmoscope properly with its battery so that it looks like you've wielded one before and that it's not just a prop. As I said, I had an eye exam in the FRACP and I was told not to do ophthalmoscopy. Again, the people examining you are out of specialty. They don't know how to do ophthalmoscopy. This is not the time to teach it to you, but it's important that you at least make the effort or say as part of the examination towards the end, I would like to perform ophthalmoscopy. Okay? Great. Thanks, everyone.